morning, everybody.
Good morning.
I'm really happy to be here. I know everyone says that, but I actually feel just so honored to be here. I want to tell you a little bit about who I am and why it might make some sense that I'm standing here and why I do feel so honored to be here. So I'm a professor in the School of Public Health in Community Health Sciences. Some of my students, former students, are here. A current student is here. But I'm a relatively new professor. I've only been there 2 years. And prior to that, I was doing what we call public health practice. I see a lot of public health practitioners here around the room. So I was at the Chicago Department of Public Health, and I worked under Dr. Shirley Fleming. So my worlds are kind of coming together, and it feels really good. You know, I've been doing public health practice most of my life, and now I'm teaching public health practice. And so for someone to ask me to talk about the assets of public health and how they might be relevant from a faith perspective, it's exactly what I want to talk about, and I'm sure that's what Elena and Wesley knew about me. So I'm going to use Prezi today to talk to you about this. Anyone familiar with Prezi? So, and this is somewhat because of PowerPoint fatigue that a lot of professors and students have, that we're using this more web-based interface, but I practiced one of these with my mom, and she felt really dizzy afterwards. She's the kind of person, if you flip the channels too quickly, you know. So we'll see how this works. So what I was asked to do is talk about what public health brings to the table in a public health and faith partnership. So what I want to do is talk about, see, we're already going to get dizzy. What I want to do is talk to you about from where we came. So a little bit about the history of public health. And I have this great fortune of my colleagues being Barney Turnock, who literally wrote the book on public health and where public health comes, and of course Linda Ray Murray, who talked to you a couple weeks ago, who I love everything that comes out of her mouth. So, so I'm borrowing a lot from what I've really learned from them and from Shirley, for sure. Thank you, that's great. So from where public health came and why we are an applied discipline. You know, we're really action-oriented. We want to get things done. I just came back from this international conference with sociologists and anthropologists, and I learned so much from them, but I also felt so good about the extent to which we are action-oriented and we want to get things done. And our research has implications, which is why we're doing things like community-based participatory research. So I'm going to talk to you a little bit about that and how are we guided in public health to do what we do. And then I'd like to talk about the data that we use to try to make some decisions on how to intervene on public health or how to improve communities' health. And where we are now, and I think this is what is so exciting to me and why I'm so happy to be involved in something like this, is that we're at this really interesting place where we're backing up really from the data and the disease condition, and we're talking about health equity. How do we build healthier communities? How do we make sure that everyone has an opportunity to be healthy? And then conclude with some ideas about public health strengths and assets, but here's where I really would like to hear from you, because I learned so much from the half of that presentation I just sat through on the strengths of the faith community, and I actually had wished I thought a little bit more about the strengths that public health brings directly related to what faith brings. So help me out when we get to that place, but I have some ideas. Okay. So the origins of public health, and can I just see who is a public health practitioner here? So it's about half and half, okay. So you can also help me out here, stop me when I interpret things wrong. But you know, like I said, I'm really proud of our tradition because it emerges and has paralleled basically social reform over time. So back from the early 1800s, we're about 170 years old, they say. And we really emerged out of issues of social advocacy and social change. And so, therefore, we're rooted in social justice. We really have been largely embedded in government activities over time. It's the other thing that makes us really different from anthropology and sociology. And even social work is that we live largely within a government setting. So we get to do really fun things like tell you to wear a seatbelt and a helmet and, in trying to improve population health. So we've been partnering with clinical medicine throughout time. I'm going to show you a little timeline in a second. But we're arguably, more importantly, a social science. So we are science-based, but we're interested in social phenomena and social interaction, and that's what I think is so unique and special about us. So here's timeline that, and maybe you have seen this as a group. This is something that comes out of NACCHO, the National Association of City and County Health Officers, who's really leading this, I think, this change in conversation on health equity. And so they put some web-based tools online, really thinking about from where we came in public health and why we're now talking about more deliberately about social justice and health equity. And so if you follow this timeline over time, you see that public health has emerged, again, parallel with social reforms and social phenomena and also challenges that we've met throughout time. So responding to epidemics, cholera, and HIV and tuberculosis, but also being responsive to social shifts. And so public health has transformed along the lines with social change having to do with, for example, racial and ethnic discrimination, gender issues, and more recently even with lesbian and gay, bisexual, transgender communities and some of those issues. So as the speaker before me was talking about marginalized populations and the faith community being there for marginalized populations, public health has a history also of responding to populations who, for whatever reason, are either outside of the healthcare system or outside of kind of the mainstream dominant systems in the United States. So, like I said, public health is a science. We're an applied science, but we're importantly this social science. So while we take a scientific approach and we have rigorous research tools and methods and data that I'm going to talk about in a second, our lens is the community or the population. So I know from what I learned from Shirley and what I teach in the School of Public Health, we're in the community health sciences, so we do things like assessment at the community level. So in the city of Chicago, that's one of the 77 community areas. So often a community, a geographic setting is our lens, but it can also be a population. We're talking about the issues of refugee and immigrant population, so not geographic, but population specific. And our concerns are basically social factors, and they have to do with social interaction. And I think that throughout history, we haven't actually been as deliberate about this as we can, and I'm going to talk about that in a second. But we've gotten really excited about data and started really talking about disease and death data instead of looking at those core roots that influence that disease and death, and that's kind of where we are now. So the study that kind of grounds us in public health is epidemiology. And this is a study of the distribution and determinants of health-related states or events in specified populations, and the application of this study to control health problems. And I just wanted to talk about that for a second, because this has been our guiding principle, basically, our tools, our science, our approach, is the study of the distribution and the determinants. And this importantly describes health-related states or events, because often we're interested in a health-related state like diabetes, or we're interested in an event like a flood, where we are public health responders to things like a flood. But it's a broad category, and this is an exciting time in public health where we're broadening this definition of health way outside of a disease category or even an event, and we're looking at who might be disproportionately affected by that event. So we study the distribution, and that's kind of our data. What do populations look like with respect to this disease condition or this state or the social factors behind this state? And then the determinants. And the determinants really do help us understand that social phenomena. Why is it that this disease category, for example, is distributed in quite this way? So distributed by gender, by age, by geography, that kind of thing. And then again, we importantly apply this study to control health problems. We're going to talk about this controlling of health problems and how it is that we're charged to do that. So I spent a lot of time making sure we zoomed out so you could see where I am in here, and it's somehow still working. So I wanted to talk about then what is public health? And this is what Barney has been writing about for years. And it's funny to be in a discipline where you're constantly having to explain what you do, right? It makes me long to be a teacher or a lawyer or a doctor. Because every conversation is like, well, kind of, well, a little bit more like this. But one of our biggest problems is that we're not really one clean system. As a matter of fact, we're increasingly telling people they're doing public health work and they don't know it. And this is a perfect example of this. I mean, I think recognizing the public health work that the faith community does, whether that language is used or not, is a perfect example of kind of building partnerships and saying, that is public health. And again, the more we redefine health to be more broad, the more we are doing public health, most of us. So we're a real fragmented system. While we mostly live within government, and Shirley and I had a long history at the Chicago Department of Public Health, increasingly it's community members, community organizations, public health agencies that are doing this really important public health work. So recognizing that. And we're inherently made up of multidisciplinary kinds of people. So whether we have degrees in sociology, social work, public health, medicine, counseling, or whether we are community organizers, we're multidisciplinary. We come at this from a different perspective. And this is challenging, I have to say, again, coming back from this international conference, with these disciplines that all have this very similar language and approach. We really have lots of different ideas and approaches, but I think that is one of our strengths. It's the strength and diversity and lots of voices and language. So this is, I don't know how many of you have seen this, but this is part of a national campaign to literally put a big bumper sticker on what is public health, and this is claiming public health. And I find this a really important opportunity to both raise awareness for what is public health and again, make new partners. So recognizing that what you're doing in public health is public health helps us kind of describe the system a little more. And again, I'd argue the more we redefine this term health, the more I think, teachers are public health. Linda Ray Murray talks about, taking gym away from young people as a public health issue.
Yeah, absolutely.
Yeah, teacher, we're really not partnering with teachers. I think I did want to say, when I worked for Shirley back in the early 90s, she was talking about this public health faith partnership. I remember, the kind of the ball starting to roll way back then, and now here we finally are. And as I just said to Shirley, it's about time. It's about time to get this kind of energy about this. And the fact that it's kind of paralleling what's happening nationally on this issue is really important. But for sure, teachers must be next. So this is, those of you in public health probably are really familiar with this, but I was asked to kind of talk about what we're charged to do in public health. And what we're charged to do is determined by two things. One is our core functions, and we have three core functions. This is going to sound a little boring and like we're in school, but the three core functions are assessment, policy development, and assurance. And these three core functions oversee basically our 11 essential services. And so I'm going to quote Linda Ray Murray a lot, and she likes to say, well, this is like marketing for public health, right? This is what we should do if we had all the resources, but of course we have a really hard time being able to do all of this, given the fact that public health really isn't invested like it should be. But what we're charged to do is we're charged to assess public health, so describe what we see, and this is what we do in community health assessment class a lot. Look at data, monitor health, diagnose and investigate, and then working towards policy development, we want to inform, educate, and empower. We want to mobilize community partnerships, and we want to develop policies. And with those policies in place, and this is both national policies that regulate things like helmets and seatbelts, but it's also local policies, so within a community organization, within industry. And then we have the pleasure of having to try to enforce laws on this. And with the enforcement of those laws, the idea is we're trying to link people to care or create a healthier place. So we also have this important function in linking to services. We also are responsible for ensuring a competent workforce, so this gets us into our insurance core function. And these are things like we're dealing a lot with trying to make sure that physicians are more culturally competent. And it's really important. As a matter of fact, we're moving away from that language competency, because can anyone be competent in anyone else's culture? And we're moving towards language like cultural humility. Kind of like, yeah. I do too. And the idea is kind of, I'm sorry, Mary is the speaker before me? Yeah. Mary, thank you. Mary was talking about tolerance, and I think this humility is tied into that too. If we could get our healthcare providers to be more humble about the patients in front of them, and not make such preconceived notions about their health. And then we evaluate. So we are this academic field, but we have this enormous amount of work to do in trying to improve the population's health. So from describing and understanding to mobilizing partnerships, making policy, to making sure that people comply. And that's, of course, the hardest part of the job. But as I saw these stickers go up along the wall, I thought, oh, I wish I had thought about how public health overlays with these functions, because we're now asking ourselves more and more to mobilize these community partnerships. And really, this is our opportunity to learn from communities like the faith community about this. So public health, as a science, as an academic study, is informed from and borrows from lots of other disciplines. The ones we talk about when we teach this are sociology, anthropology, psychology, and what we basically pull from those disciplines is really the understanding of people and how they interact. So while public health has grown up pretty closely tied with medicine, and we spend a lot of time with disease data, we should be spending more time maybe understanding how communities operate, how people's health is influenced by the context in which they live. So we're learning a lot more about health behavior this day, but want to understand why might someone engage in that health behavior and someone else not? How does context matter? So we pull from these disciplines, and this shapes our tools and our data, and that's what I want to talk about in a second. I'm kind of a data geek, so. But we also, of course, are partners, very close partners with nursing, public policy, urban planning, and social work. So I think we're at this advantage in that we get to do this applied stuff, but we pull from and we borrow from this kind of continuum of the social sciences to try to do our job better. Or at least that's the way I like to think about it. Data. So what's fun in public health is that we have this array of data to pull from to help us assess, describe, and understand health. And as Mary was talking about the role of stories, I was thinking, that's becoming a more real form of data in our science. Kelsey and I were at this conference about qualitative data last week, where we were really understanding how can we use people's stories and people's narratives better in a more rigorous way, because as a science, people keep throwing the word rigor in our face. But the stories are what people remember, and the stories are what are useful for policy change. So we can throw all the data we want up against the wall, but unless we frame it in a story, we're not going to get anywhere. So we threw this picture up here about John Snow and cholera, and the public health people in the room know all about John Snow, but he really shaped the way that we think about health and the kinds of data we use. And this was back in England in the early 1800s, where there's an epidemic of cholera, and John Snow, who was a physician at the time, no one could figure out why the death rates were so high. A plague, really. It was a terrible epidemic. And John Snow, through the use of really walking the streets, talking to people, and starting to map who was dying, and he had this hypothesis that it had something to do with the water system, which of course at the time was terribly contaminated. And he started taking a map and mapping where people were dying in relationship to water pumps, and came up with this hypothesis, hey, basically, there might be something to this idea about germ theory. And what if we took the handle off of this pump? And he talked the city planners into taking the handle off of the pump, and sure enough, the deaths almost started to cease around that area. But I bring that up because we talk about shoe leather epidemiology. So epidemiology has this definition that sounds more clinical and quantitative. Shoe leather epidemiology, really walking the streets until your shoe leather is beaten down, has this long history, this hundreds of years old history in trying to understand communities' health. Oh, look at that, I focused right in on it. And of course there's a pub right next to the pump now called the John Snow Pub, importantly, right? Okay, so this is the kinds of data that we use then in trying to understand health, and I would argue community health, because that's most often our lens is community health. So we have death data, and so this is mortality data, and it's really important to us because we can figure out a couple things from death data. Of course, just like in John Snow time, we count up the number of people dying for certain conditions, and that's a great big red flag that something's wrong. But we can also look at when people die, and that tells us something about life expectancy. And of course, in the United States, and Dr. Murray probably talked about this, our life expectancy isn't as long as it is in some other countries, suggesting there's something wrong, and she would argue it's racism, discrimination, social inequality that we haven't really fully explored. That does feel like the path we need to understand. Infant mortality, we have disparate experiences in infant mortality by income, by race, by ethnicity in the United States. Terribly shameful that that happens in the United States, but that data is useful to us to raise this flag. There's something wrong, whether it's a geographic community or a population community. And then disease-related mortality, asthma, diabetes, obesity, if we can tie obesity to mortality, a really useful kind of data for us. So that's quantitative data, that's numbers. And then we also use birth data, and we often talk about these kinds of data as maternal and child health data. And this tells us a lot of things about the experiences that populations are happening. So if we see, for example, low birth weight babies being born at a birth weight that's concerning to us, then we are concerned, and we think that there's something within that community that might be influencing the birth weight of babies in that area. Age of mothers, right? We have a problem with teenage pregnancy in this country. When mothers receive prenatal care, so that's part of the birth record, so we kind of lump that in with maternal and child health data. Increasingly, I'm not sure how important this is, to be honest. The more we start talking about social factors, the less I'm concerned with receipt of prenatal care, but it's a classic indicator of health when women access the healthcare system for prenatal care services. And then we use morbidity data. So these are disease data. And the problem with disease data, of course, is it's the people who access the healthcare system and get diagnosed with the condition. So there's always this huge caveat. But it's also really helpful to us because we see disparities in disease data. We see higher rates of asthma, diabetes, obesity among African American and Latino patients. That's a concern. We can also look at hospitalization. So those of you in public health here know about ambulatory care sensitive conditions. Because I'm a data geek, I remember learning about this measure, and I was like, that's beautiful. The measure basically means it's a condition that a person was hospitalized for and shouldn't have. That there's something in the ambulatory setting or the community health setting that should have prevented that hospitalization. So we often think about dehydration as one, asthma is one. Asthma should be controlled within your community provider. If you're hospitalized for it, that's a problem. There's some kind of disconnect with how you interface with your community provider.
What did you call that? Yes.
Ambulatory care sensitive condition. Yeah. And this is data that really, Shirley might remember, but I think we started publishing them at CDPH in 2000. I'm not even sure if we did before then, but it's a really good measure. And we can look at it geographically. So we see, for example, rates of hospitalization for children. We can map it in the city of Chicago, and we can see clusters of where children are hospitalized for asthma, where it should have been taken care of in the primary healthcare setting. And that's a primary function of public health, is to look for those gaps in care. So that's why it's just a really good measure. I'm thinking about it, I'm excited that you like that term, so I'm trying to think about other examples. But kinds of infections too that you should be able to control. By the time you're being hospitalized for an infection, you basically don't have a competent healthcare provider seeing you, and probably you don't have one at all. So kind of moving down the
I'm saying you don't have the resources.
Don't have the resources. Yeah. That's right. So kind of moving down the kinds of data, and I think the kinds of data that might be more valuable to us maybe, these quantitative data give us a really good description of what's happening in the community, but it is this more qualitative data, the stories and the experiences, the lived experience of people are happening, that might be most helpful in thinking about what an intervention might be or how we can improve overall population health. So these are health behavior data. We collect these typically through survey research methodology, so whether that's Steve Whitman and his team going door to door collecting a survey or national population-based survey. So we get some sense of whether people are wearing their seatbelts and helmets. It's always the thing that pops up in my head, but exercising, eating well, the behaviors in which you engage in towards your health. And then quality of life and perceptions. I'm going to talk about that in a second when we talk about qualitative. So with our more quantitative data, our numbers, we look for red flags, like I said. We look for prevalence. How prevalent is this condition within this population? What's the incidence? How many new cases are popping up? That's a flag for a problem. And there's a lot of people, Dr. Murray and Dr. Fleming, I know, who also suggest, that basically we started engaging in risk factor epidemiology, people say. We started using this data to try to understand relationships between, for example, demographics, so race and income, and a disease outcome. And we published lots of papers on that, and we gave lots of talk on that. But that relationship didn't tell us anything about, well, how might we intervene on this situation? The fact that there was a relationship between race and a disease outcome told us a red flag was there, but it doesn't help us understand the problem. And I think this is where my colleagues and I are starting to get really excited about partnerships like this and qualitative methods where we hear stories and lived experience, because it's only in understanding the context in which that problem exists that we can come up with a meaningful intervention. And some would argue, well, public health isn't going to come up with a meaningful intervention, the communities are. And so that's why we need to be at the table. So this risk factor epidemiology is a problem, we think, because we spent too much time kind of discerning these relationships and, like I said, publishing on this and getting lots of money for health disparities research when maybe we should be thinking about health equity.
Absolutely.
Yeah. My heart races a little faster when I talk about this because it feels kind of so obvious to me. And I think from my public health practice and now teaching this, and really the pleasure of teaching public health and having people kind of nod and add their 2 cents in, I've learned so much just in 2 years, and this just feels very good to me that we're moving in this direction. So the direction that we're moving in, some would say is really mixed methods. We're not going to let go of our death data and our disease data. That's really important. And epidemiology is really important, but maybe we should start thinking about social epidemiology. What does the distribution and the determinants of social factors look like? And that's really exciting to me. That would get us to potential solutions. What might an intervention look like? How might we solve this problem? And often our solution is a policy level solution. Doing something about poverty would be really, really helpful. So really pushing poverty as part of the problem instead of, again, maybe looking at 2 variables more narrowly. So anyway, that gets us to qualitative methods. And this is the methods orientation that we basically stole from anthropology and sociology. And we find them very, very useful. So interviews with individual people, focus groups with groups of people. And this is very simple, and I know you all know about this kind of data collection. But really doing it well, making sure that you hear from individuals and basically understand the nature of what they're saying. And I think historically understanding the nature of what groups of people are saying wasn't science. And we're really pushing this, like, sure it is. Why wouldn't it be? And the same way as why stories matter in the faith community, stories matter in public health. We're revisiting John Snow's ethnographic assessment, or shoe leather epidemiology, being in communities, getting out of our offices, using observation or participant observation to understand health phenomena. And then, of course, we have lots of really cool tools to use in trying to do this. So taking John Snow's pencil and paper, or maybe he used a feather, I don't know. My history's not very good. But using geographic information systems, of course, we can collect data now from our cell phones, and they're immediately synced with something really cool in our office. In addition to the qualitative conference I went to last week, I went to this technical conference and got all excited about the kinds of data that we can collect now with mobile units, so that we can both collect people's narrative experiences, we can have them respond to a survey, and then we hit a button and we basically just mapped that person geographically. And the person that was presenting this last week does basically disaster relief in third world countries, where he said, yeah, we can use all these methods and collect all the data, but it'll take us a year to analyze it, and we don't have a year. We literally need to turn the data around. So it's really exciting the rate at which we can now collect data and immediately share it. So technology is really helping us with that. And then these newer tools to public health, again, they've been around in some other disciplines, but using photographs to tell stories. I have this dream I've kind of ran by Shirley right before I started talking about using community assessment for more practical good, basically. I teach like 40 to 60 students every semester, twice a year, and they collect data. And we try to make that data meaningful, but often someone nods and says, thank you so much, that was really helpful, and then it sits on the shelf. But if we could actually collect data in partnership And we could share that data, and the next group of students could build on that data. We could actually be teaching students and helping communities at the same time. But anyway, what the students love is the use of photographs, because again, you're using your phone. And that photograph helps tell that story. What's better than having my students take the photos is have community members take photos, and that's something called photo voice or photo elicitation. And that's moving away from quantitative numbers and using photos to try to describe and understand social phenomena. So this has all moved us towards thinking more about ecology or context, and these are two words we use all the time in public health now. We use what's called the ecological model, which really just suggests that individuals exist within these contexts, so within their families, their communities, society. So we like to think of, you've probably seen this, maybe Dr. Murray showed this, but circles within circles. So while we've been talking about socio-ecological model for years, I think we're really just now pushing ourselves to say, well, what does that really mean? I didn't really mean this to be off like that. But as we think of an ecological perspective, forces us to think of these social determinants. So what is it about the social institutions within our context, the social surroundings, and again, our relationships, social interaction? And that leads us to these conversations about health equity. And I wanted to point out, while I shared the 3 core functions and the 10 essential services, 10. I throw an 11th in there for fun. I don't know what that would be. These are basically our rule book from the National Institutes of Health or the Centers for Disease Control and Prevention. And because public health sits largely within government, this is where we kind of get our marching orders. And so I think it's important, and I wanted to share, in 2001, the Institutes of Medicine, who also is part of that kind of regulatory body over public health, really nodded to community and context and ecology. I think if I hit on this, yeah, we'll focus in here. And really the Institutes of Medicine, which, as you know and can imagine, has a real clinical orientation and really favors the quantitative measures of mortality and morbidity. It suggested that individuals and families are embedded within social, political, and economic systems that shape behaviors and constrain accesses to resources necessary to maintain health. So that's very obvious to everyone in this room, but it was really meaningful that the Institutes of Medicine recognized this. And they basically said, in public health, we need greater emphasis on interventions that involve communities with the goal of collectively identifying resources, needs, and solutions. So this wasn't too long ago, but it was a really important moment to nod to our efforts maybe to back away from this risk factor epidemiology or this more narrow thinking about how health matters, and do it both in partnership with communities, so exactly what's happening today and happening all over public health nationally, collectively identifying resources, needs, and solutions. And I heard Mary reference John McKnight from Northwestern, who does asset mapping, and really in the 1990s started getting us to think about assets instead of deficits. What a subtle shift, but so important. If we didn't identify the assets, then how do we build on anything? And really for a long time, all we were doing was making lists of deficits. So this really subtle shift from John McKnight made a world of a difference. But also identifying assets with community partners instead of public health coming in and saying, well, there's a church, that's an asset. Having community members tell us, what are the strengths of the community, both individuals and organizations. That's what John McKnight would say. That we've overlooked individuals, and Mary was talking about specific individuals that might have experienced marginalization. What assets do they play in the community? That's a really important way to think about it. And talking about the fact that we're embedded within social, political, and economic systems, and that that context shapes our behavior, had also started pushing this conversation that place matters, and that people don't have the same opportunities to engage in healthy behaviors than others. And I heard someone mention unnatural causes. Mm-hmm. Have you watched that with this group? This social documentary that's really very clearly started describing the extent to which place matters. And I think for a long time, we were asking physicians, really, we were blaming health problems on individuals and asking physicians to just, could you talk more about health behaviors? You know, eating right, exercise, stop smoking, you know, please, you know, take your medicine. And what we did is we put all of that onus back on the individual. We also put it on the physician, who has no time for a great deal of health behavior talk and paid no attention to the context in which that person lives. So why I think we're at a really exciting place in public health is basically that we've forced ourselves to really start thinking about these social factors. So even using that last example about smoking, eating, and exercising, and thinking about, well, what does the context in which this person, this community exists, what does it look like? And some of it forces us to look at data like disparate utilization of advertising for alcohol and smoking, the fact that low-income communities have more advertisements for negative health behaviors than others. Had we not started counting that, thinking about that, we wouldn't have thought about that factor influencing health behaviors. And then the very obvious ones that we were talking about, food deserts. And we hadn't really thought about access to healthy foods. We were telling people to get healthy food and eat them, but we hadn't thought about that people have disparate experiences relating to accessing health care. And actually, yeah.
And may I say that there may be health care deserts soon?
Yeah.
If the safety net hospitals have significant cuts to their funding, some of the safety net hospitals across the state of Illinois may have to close.
Absolutely.
And so there will be health care deserts as well.
Absolutely. And I think what we're doing, public health's doing in response to that, because I think you're right, that's this very big scary thing in front of us, is relying more on the communities themselves. So can we arm community health workers to try to help? Can we do lay health workers? And it's putting more onus on the community to improve its own health because the system's just not there. So some things that are very exciting though, and I have to say I was talking to some people from NACHO who talk about health equity all the time, and they're coming up with 2 new measures to think about community health. They're not new, but they're kind of coming up with gold standards on this. And one is walkability, something we didn't talk about 10 years ago, but now makes so much sense. We tell people to exercise, well, how walkable is my community? Whether sidewalks are there or whether it's safe, or perception of safety. Shoot, I'm forgetting the other one, but it will come to me. But it was like a new kinds of data, new ways of thinking about it. And what we would do then is, of course, partner with community members to help us collect and understand that data instead of public health workers coming in, collecting the data on clipboards and leaving. So that leads me to CBPR, community-based participatory research, which I think most people who've been doing public health practice for a long time are really excited by this idea. And I think very simply it's because we have been identifying disparities in health outcomes now for decades and haven't really made the progress that we need to try to make those less disparate. Now I would argue it's because we should have been talking about health equity rather than disparity, which is what Dr. Murray suggests. But community-based participatory research gives us this opportunity to try to identify solutions instead of just look at how different these are. Look at these disparities. We're really moving towards, well, how might we make a change on that? And how might we change opportunities so that everyone can be healthy? And that forces us to talk about these social factors that, while our discipline has this history in social reform, really operationalizing these, measuring these is new for us. And it can be hard and scary, but it's exactly at the roots of these problems. So the effects of poverty, the effects of racism, the effects of discrimination, how these affect people's everyday lives, but also how they affect health-seeking behavior. So we see differences in how people access the healthcare system because of these issues of discrimination. And that gets us to different kinds of data. So Mary was talking about social capital. We talk a lot about social capital and cultural capital, and a term that was coined just 2 years ago that my students know, like a paper came out, and I was so excited about it because it was called cultural health capital. So this is a term, has anyone heard of cultural capital? Mm-hmm. So this is a term, the word capital really meaning resources, stuff, skills. So the extent to which marginalized communities are able to navigate mainstream systems. And so in public health, we talk about the healthcare system. But we suggest that there's barriers to access, financial barriers to access, availability barriers to access, but then there's also barriers to interfacing with the healthcare system and getting good quality health information, and we call that cultural health capital. So just coming up with these constructs that are well beyond disease and death, and really thinking about, well, what might that look like, and how might we build something like cultural health capital? And what we're talking about in this arena are things like health literacy. Well, can we work in partnership with communities so that people can navigate the healthcare system in a more effective way because they know the questions to ask the doctor, and they know the treatment that might be best for them, that kind of thing. And it gets us to talking about place and community like we haven't before, and really measuring place. So I'd like to hear from my colleagues in public health on this, because from my lens, I feel like public health has these strengths to bring to a partnership like this, that are our history and science, our use of data, our rigorous tools, biostatistics that no one wants to do but public health people. So we can describe the healthcare, and I think that's what we have been doing well for decades, is describing. But now we want to step into the area of understanding, and that's where we need to partner with communities. And I would argue that we're uniquely prepared for this partnership. It's the fact that we haven't been able to reduce health disparities in the way that we would like that have led us to, there's no choice but to partner with communities. This is the place to help us find solutions. So we're prepared to both inform from our theories, our methods, our science, but also be informed by others. And I think the fact that qualitative methods is part of our toolbox now is demonstrative of the extent to which we want to be informed by others. The fact that we're more willing to talk health more broadly defined now is to our advantage. It makes us have the opportunity to make new partners with people that we wouldn't have been partners with before. Like I said, teachers, gym teachers as a public health partnership. And the fact that we're action oriented. We're less interested, public health practitioners, than publishing and making a big name in our academic settings. We really actually want to make social change as part of our mission, as our discipline. And then I guess I want to end with the tools that are available to us. Really cool things like Prezi, but really these mobile tools that data is more broadly defined, these constructs are more broadly defined, and then we can measure them in these really interesting ways. So even these walkability surveys, and with the shoe leather epidemiology, we can collect and synthesize information as it goes. So I think that should very much be considered our strength, is that we're developing tools that allow us to respond in a rapid way and create information that informs communities. And informing communities, I guess I just want to end with one thing about a partnership with communities. So communities broadly defined, whether it's a faith community or another kind of community. What public health is more interested in these days is something called member checking, which is, do we have this right? We looked at the data. This is what the data looked like. Is that what the data is like? And so I think what that's doing is it's valuing that lived experience on an equal par with the data. And that seems really meaningful to me, because the data can describe something, but if the lived experience is different, if the perceptions are different, then we're not going to get anywhere in that partnership. Any questions?
How involved is public health with accountable care organizations?
Accountable care organizations?
ACOs? Are you
No.
familiar with them?
Well, I'm not, I don't know.
Because within the construct of ACOs, there is health community advocates that, and so I would think that public health would be very interested in some, and I know at UIC, we've applied for grants for several ACOs, like in chronic kidney disease is one area. I believe diabetes is another area. So, and they actually, and I was involved a little bit peripherally with that, with chronic kidney disease. And they actually, which I thought was just one of the greatest things, is they had a community care advocate who was going to be one very busy person. because they were going to help to bridge the language and the availability as well for the patient with the healthcare system. So I was just wondering if public health is actively involved in ACOs, because I would think that would be a perfect spot.
It does sound like a perfect spot. You know, and I might not be the right person to answer it, someone else might, but it sounds like a lot of other efforts we're doing with community health workers and lay health advocates.
Exactly, yes. That's exactly what that was.
Kristen, did you want to?
Yeah, actually, I was sort of thinking along the same lines as I was hearing you talk, Jennifer, that I think now is an opportunity for there to be greater partnership between public health and healthcare providers as well. That a lot of that because of some of the shifts with the new healthcare law, there's really healthcare providers are now starting to sort of get interested in some of the kinds of things that public health are doing, and that it might be interesting even for the next institute to be an institute of faith, public health, and healthcare together, all together. Because as Mary mentioned, a lot of healthcare providers are also faith-based, so it makes nice. But yeah, I mean, healthcare providers are getting very active because we have to, because of the new legislation, in looking at how our institutions, and come from a healthcare provider organization, how our institutions Sorry, I kept wanting to say interfaith. But then I'd just be lifting. Interface with the community and this idea that it isn't just the health of the individual, but the individual is actually in a context. But there's so much we need to learn about that from public health because we're just not in that mindset.
And I think we're also saying it's not just the individual, and we're also saying it's not just the doctor. I mean, for a long time, public health was saying, if you could just speak the language, if you could just be culturally competent. And so all that onus on the physician, when really it's the social factors that play, this is where some really interesting research is that social factors disproportionately play a role in racial and ethnic and income disparities than medical care. So the doctor is more willing to partner when the onus isn't all on the doctor. Really good point.
I'd like to thank you for sharing. This is a wonderful presentation, particularly the allied professions or disciplines that you shared. I think that looking at that's very, very interesting. What would you describe as the chief differentiator between community psychology and public health?
That's a great question. Are you a community psychologist?
In training, yes. I heard from community psychology practitioners, so I was just interested in the public health.
So I'm a community psychologist wannabe, kind of.
Okay.
So, you know, I think when I was going through my school, someone said, hey, what about community psychology? I started taking classes, and I said, we speak the same language. And I send a lot of my students over to community psychology at UIC. And as a matter of fact, I was making this argument at this conference this week that one of the problems with public health is that we don't have this rich theoretical tradition, that we're so action-oriented that we don't, like sociology or anthropology, have all of these philosophers and theorists that guide what we do. We just want to get it done. And someone said, well, what about community psychology, that we borrow a lot from community psychology? I think we do, maybe not deliberately, but I think that's exactly right, that it is, that public health is oriented in a community psychology way, whether we talk about that or not. So I know in our school of public health, we have more joint appointments between faculty, which is really a welcome addition, that we're recognizing we're speaking the same language.
You know, just hit me as you were presenting about the ecological model and the things that impact poverty, race, and all that. As we swim upstream and talk about health equity, one of the things that I seldom see listed, and that is history. You know, I think that history is huge. Not only the individual or the cultural history, but the national history. It all plays a huge part.
I think it's a great point. And when Mary was talking, I actually scribbled down history to remind myself, because you're right, it's missing in that. And when we do community assessment, we say, you know, don't do this ahistorically. Don't pretend like when you walked in that community, the data you collect is now going to describe that community, that you're missing everything that came before. And I know, particularly when we're thinking about how people access the healthcare system, when they decide to seek care, to whom, is shaped by historical experiences of that came before. So that's a really good point. I'll make sure it's on there in the future.
Yeah, I agree. I always tell my students, you know, do you think a patient's going to listen to you or their grandma? I listen to grandma.
Do you know, I actually had this cool image that I decided to take out, which was grandma trumps the doctor. And in all of our research, that's right. As a matter of fact, I do research with adolescent mothers and their experiences of accessing healthcare center, the healthcare, and issues of sleeping with your children, of food, of child rearing, breastfeeding. You know, that's not what grandma says, and grandma always trumps. Yeah.
I participated along with other faith leaders that was led by the Center for Congregations and a Positive Deviance process. And I just wondered if that methodology has a place in, as we're exploring ways to identify problems where that problem may not be a problem in certain places.
That's great. Can you tell me more about that?
The pastors were in Gary, and they wanted to explore the possibility of using that way of understanding a problem in Gary, and if the faith community could come together and work together to its solution. But we tended to center and determine that that Gary is a food desert, and there are many problems related to that connects with our children who are obese. Our children that live in these communities, they frequent the convenience stores, the food that is provided in the schools. All of that contributes to that. So we brought it to an end, I think, kind of prematurely, but it was left to the pastors, to the leaders that participated in that group to take it to the next level.
I haven't heard that term. It sounds completely suited to how public health would partner in something like that. Have you heard that term?
I heard that term.
Positive deviance?
Positive Deviance, and there's a book that has that title.
Okay.
Yeah.
You bring the title next month?
Of course.
Yeah.
Okay.
Yes, one more question?
Yes, getting back to the term of capital, health capital, public health
Cultural
capital.
capital?
I noticed, well, I shouldn't say noticed, I've noticed how certain cultures, or a particular culture, can, in my definition of the use of capital, can have their capital decrease because of public perception. For example, we hear radio ads that a particular culture always has the highest this or the highest that. It affects how other cultures will treat that culture economically. And that decreases that culture, that capital within that culture. Or it can increase some culture's capital, all because of just a perception. And we need to know the information, yet having the information can also decrease those things.
Yeah. You know, the concept comes from this French philosopher, Bourdieu, who used this term to think about, he was looking at data in the educational system in France, and he said, how is it that some students do better than other students in navigating the school system? And he came up with, you know, some students knew the language and the how to get the best teacher and how to get scholarships, and others didn't. And what was that all about? And he basically came up with this hypothesis that they had learned the culture of the school system, and they were able to navigate that better. Now, they learned it because family members taught them, or it was a learning they didn't even know they were learning. And so this concept just recently has been applied to the healthcare system in the United States. Dominant mainstream system that some people navigate better than others, and again, sometimes that's because of affordability and access into the system. But even when we're in the system, some people navigate better than others, and why is that? So it's just this idea, but you add to that concept as something I think more rich, but it is this idea that that maybe if we look at how people are navigating the healthcare system and with what language and perspective, and he calls it habitus, how they approach the healthcare system, maybe we can understand those experiences more. But I think you add an important dimension that didn't emerge out of Bordeaux and this one way of thinking about it.
How are you spelling Bordeaux, please?
B-O-U-R-D-I-E-I. It's like Bordeaux, right?
B-O-U-R-D.
Bordeaux, yeah.
Okay, thank you.
And this term cultural health capital, like
Habitus, it'll come up.
this idea of cultural health capital just came out in 2010, but now people are saying, oh, well, maybe that relates to health literacy. So we're kind of making this jump to if we build health literacy, meaning how to understand health better within communities, they can better navigate the healthcare system. Feels like only one route, but still a kind of important one. So.
We also have to deal with the issue of trust. That's
Yes.
that's the intangible. That's the elephant in the room.
Exactly. And most of what we know about trust has been measured within the healthcare setting itself. So in retrospect, from patients' perspectives, how much did you trust that interaction with your physician? How much did he respect you, take time? Something else, there's 3 things. I'm looking at Kelsey. Trust, respect your decision making.
Yeah, just
Right? And Levis does a lot of work in this area, but some people argue, well, that's just the patient. But the patient got into the healthcare setting. It's more from the community perspective, these issues of trust. I don't think we're measuring those at all.
And that goes back to history.
And that's history, exactly, yeah. Any more questions? I'd stand here all day, and I know Shirley's standing there for a reason, so. Thank you so much.